Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 327 of our pharmacotherapy series, which majors in diabetes mellitus. The first question refers to patient JVC from part 326 of this pharmacotherapy series. How often should JVC monitor her blood glucose? The eventual goal for children with diabetes is self-management, with insulin dosing decisions based on interpretation of blood glucose results. Self-management skills and basal bolus insulin regimens rely on frequent self-monitoring of blood glucose. For children with type 1 diabetes, 4 or more blood glucose tests per day are generally necessary. Many home blood glucose meters allow for alternative site testing, arm or thigh, which decreases the discomfort of fingersticks. Enthusiasm for frequent blood glucose testing tends to wane with duration of diabetes. However, families who are instructed on managing diabetes on the basis of test results are better motivated to persevere with self-monitoring of blood glucose. Continuous glucose monitoring may also be considered at some point for improved assessment of her metabolic control, particularly to detect nocturnal hypoglycemia. JVC should test her blood glucose before each meal and at bedtime, at a minimum. Additional tests should be performed whenever JVC experiences hypoglycemia, ketonuria, or when she becomes acutely ill. The next question reads, during the next 2 months, JVC's insulin requirements decreased to a total daily dose of 10 units, approximately 0.3 unit per kilogram. Has her diabetes gone into remission? Approximately 20% to 30% of individuals with type 1 diabetes go into a remission phase, that is a honeymoon period, within days to weeks of the diagnosis. During this phase, which can last for weeks to months, insulin requirements can fall well below the usual initial dose of 0.5 to 1.0 units per kilogram per day, and C-peptide can be detected, indicating a return of pancreatic function. A child may require minimal to no basal insulin replacement, and mealtime replacement requirements may need to be reduced. As illustrated by JVC, this presents clinically as markedly decreased insulin requirements to maintain normoglycemia. JVC should continue to perform self-monitoring of blood glucose and closely monitor for rising blood glucose concentrations, as beta cell destruction continues during the honeymoon phase, and she will eventually return to higher insulin requirements. The next question reads, JVC's parents contacted the clinic to report that JVC is having nightmares and is awakening in the middle of the night complaining of a headache and stomach pain. However, these symptoms resolve by noon the following day. Her current insulin regimen is insulin aspart 2 units before meals and 3 units of insulin glargine twice daily, that is at breakfast and bedtime. Could JVC be experiencing nocturnal hypoglycemia? How do the symptoms of hypoglycemia differ in a child compared with an adult? How can the risk of hypoglycemia be minimized for JVC? JVC's parents are appropriately worried. Hypoglycemia is a serious and often life-threatening complication of diabetes management in children, and the risk of hypoglycemia increases with attempts to maintain meticulous control of blood glucose levels. It was previously thought that pediatric patients may be at risk of cognitive impairment following severe episodes of hypoglycemia. However, current literature does not support this finding. Common causes of hypoglycemia include changes in carbohydrate intake, late or skipped meals or snacks, exercise or unusual activity, and administration of excessive insulin. Because very young children may not be able to identify or express symptoms of hypoglycemia, caretakers must observe the child closely and identify symptoms or behaviors associated with a falling blood glucose. Symptoms of hypoglycemia may include crankiness, sudden crying, restless sleep, or nightmares as seen in JVC. Hypoglycemia is more frequent in children with lower A1C values, a prior history of severe hypoglycemia, larger insulin doses, and younger children. Nocturnal hypoglycemia is reported in 14% to 47% of children with type 1 diabetes and is thought to be related to impaired counter-regulatory response to hypoglycemia during sleep. Bedtime blood glucose levels are poor predictors of nocturnal hypoglycemia. JVC's parents should be instructed to test her blood glucose at 2 a.m. closely for the next few nights, and then continue to check at least twice weekly. In children, insulin glargine can exhibit a small peak effect during the initial 3 to 5 hours after administration, increasing the risk for nocturnal hypoglycemia. If this is the case, the insulin glargine dose should be moved to dinner time or in the morning. If this does not correct the nocturnal hypoglycemia, then the dose should be reduced. Use of insulin glargine is associated with less nocturnal hypoglycemia and asymptomatic nocturnal hypoglycemia compared with neutral protamine hagedorn insulin in children and adolescents. A bedtime SAC may also be needed. Treatment of hypoglycemia is addressed in the previous case. The next question reads, GMS, a 32-year-old woman with type 1 diabetes, has been well controlled on a basal bolus regimen, 4 injections daily, for the past 6 months. However, 2 days ago, she began to exhibit signs and symptoms consistent with the flu. This has made her nauseated, and now she has begun to vomit. Consequently, her food intake has been minimal. Because GMS is not eating at this time, should she discontinue her insulin? Insulin requirements always increase in the presence of an infection or acute illness, even if food intake is diminished. Patients with type 1 diabetes, such as GMS, commonly decrease or eliminate insulin doses under these circumstances, and it is in just this setting that ketoacidosis may occur. Therefore, GMS should be instructed to maintain her usual dose of insulin and test her blood glucose and urine ketones every 3 to 4 hours. If blood glucose concentrations are above the usual range, extra doses of her rapid-acting insulin should be administered according to a prescribed algorithm based on her body's sensitivity to insulin, e.g., 1 unit for each 50 mg per deciliter above her blood glucose target. People with type 1 diabetes should be instructed to test for ketones if their blood glucose concentration is 300 mg per deciliter or higher. GMS should call her physician if her blood glucose concentration remains more than 240 mg per deciliter after 3 corrective insulin doses, if she has moderate to large amounts of ketones in her urine or blood, if using a meter that can measure these, if she has been vomiting or having diarrhea for longer than 6 hours, or if she begins to experience signs and symptoms related to ketoacidosis, such as polyuria, polydipsia, dehydration, ketonuria, and a fruity breath. GMS also should attempt to maintain her fluid, mineral, and carbohydrate intake with easily digested food and fluids. The next question reads, CMB, a 32-year-old woman, has had type 1 diabetes for 15 years. During the past 2 years, a gradual deterioration of her renal function, as reflected by increased proteinuria, serum creatinine, and blood urea nitrogen values, and reduced glomerular filtration rate, has been observed. What are the anticipated effects of decreased renal function on CMB's insulin requirements? The effects of renal failure on insulin requirements are complex, and under various circumstances, insulin requirements may increase or decrease. The kidney is the most important site of extrahepatic insulin metabolism and excretion. In non-diabetic individuals, the liver extracts approximately 60% of insulin secreted endogenously before it reaches the peripheral circulation. Because exogenous insulin is delivered directly to the periphery, the kidneys play a more important role in its elimination. Insulin is filtered by the glomerulus and reabsorbed in the proximal tubules, where it is destroyed enzymatically. The kidney also clears insulin from the peritubular circulation. At that site, insulin can enhance the reabsorption of sodium, which may account for the edema occasionally observed after the initiation of insulin therapy in some individuals. Diminished renal function can be accompanied by decreased clearance of endogenous and exogenous insulin, resulting in increased plasma concentrations of insulin. Therefore, CMB's insulin requirements may diminish as her renal disease progresses. Patients with moderate degrees of renal failure, that is a GFR above 22.5 ml per minute, remove 39% of insulin from arterial plasma, similar to normal subjects. In contrast, patients with severe renal insufficiency, GFR below 6 ml per minute, have a marked reduction in insulin removal from arterial plasma, 9%. Decreased insulin clearance in conjunction with nausea and decreased food intake associated with uremia can lead to hypoglycemia in such individuals. In some patients with diabetes mellitus, particularly those with residual endogenous insulin secretion, e.g., type 2 diabetes, glucose tolerance may normalize as renal function diminishes, eliminating the need for insulin. In contrast, severe uremia is associated with glucose intolerance. This seems to be related to tissue resistance to insulin secondary to an unknown factor that can be removed by dialysis. As CMB's renal function worsens, a reduction in her insulin requirements should be anticipated. The next question reads, KAG, a 55-year-old, 60-kilogram woman with a 35-year history of type 1 diabetes was admitted to the critical care unit for an abdominal hysterectomy. Before admission, she was well controlled on 24 units of insulin glargine at bedtime and pre-meal doses of insulin aspart. How should KAG's diabetes be managed while in the critical care unit? Patients with diabetes account for more than 1 in 5 hospital days in the United States. Of the nearly $176 billion that is spent annually on diabetes, nearly half is spent on inpatient care. A clear, linear relationship exists between hyperglycemia and adverse clinical outcomes in the hospitalized patient. However, this relationship exists regardless of a baseline diagnosis of diabetes at the time of admission, and iatrogenic hyperglycemia in the hospital does not have the same relationship morbidity that spontaneous hyperglycemia does. These observations have raised important questions about the relationship between hyperglycemia and morbidity in the hospitalized patient. Complex responses to acute illness including excess secretion of catecholamines and cortisol result in peripheral insulin resistance and so-called stress hyperglycemia. This makes it difficult to discern whether glycemia is a marker or a mediator of adverse outcomes in the acutely ill patient. Accordingly, historic practice had been to only aim for blood glucose concentrations that prevent glucosuria, that is below 200 mg per deciliter, and the subsequent risk for dehydration in the hospitalized patient. However, beginning in 2001, a series of randomized trials tested glycemic control in the critically ill patient. Significant changes have subsequently been made to practice recommendations for both the critically and the non-critically ill hospitalized patient. Although several trials beginning in the 1990s tested intensive insulin regimens in patients with acute ME, they were small, placebo-controlled studies and reached different conclusions that proved difficult to rectify. In 2001, the first of the Van den Berghe trials tested two different levels of glycemic control in a relatively large number of surgical intensive care unit (ICU) patients with hyperglycemia with or without known diabetes. A liberal glucose control strategy, reduction only if blood glucose rose above 215 mg per deciliter, was compared with normalization of blood glucose 80 to 110 mg per deciliter. Overall, normalization of blood glucose significantly reduced ICU mortality from 8.0% to 4.5%. However, the same researchers were unable to replicate their findings in a subsequent, similarly designed study in medical ICU patients with substantially higher baseline mortality rates. Although a substudy showed that an ICU stay of 3 days or longer was predictive of benefit from tight control, a subsequent and much larger trial not only failed to confirm that finding but found increased mortality from a blood sugar of 80 to 110 mg per deciliter compared with 140 to 180 mg per deciliter, 27.5%, 829 of 3010 versus 24.9%, 751 of 3012. The incidence of severe hypoglycemia, that is below 40 mg per deciliter, in the different study groups assigned to tight control was between 7% and 18% and did not explain the different findings between studies. However, several important differences between these trials, which helped to inform current guidelines, should be noted. The 2001 Van den Berghe trial used parenteral nutrition in all patients and allowed for higher glucose values. Insulin started if blood sugar exceeded 215 mg per deciliter to occur in the conventional glycemia arm. It is therefore possible that the aggressive insulin therapy in the tight control group helped to blunt the excessive glucotoxicity that may have been occurring from the parenteral nutrition. In the second Van den Berghe trial, as in the NICE sugar study, parenteral nutrition was rarely used and initiation of insulin therapy in the conventional arms began at blood sugar values greater than 180 mg per deciliter. Additionally, in NICE sugar, a more aggressive target of less than 180 mg per deciliter was used rather than 180 to 200 mg per deciliter as in the two Van den Berghe studies. Overall, numerous individual studies as well as meta-analyses have reached different conclusions regarding whether or not tight control of blood glucose is superior to conventional control in the hospitalized, acutely ill patient. In 2009, the ADA made substantial changes to its 2005 guideline on management of inpatient hyperglycemia. Although existing randomized trials of glycemic control have been performed in critical care settings, the ADA guideline included non-ICU settings. To make recommendations for non-ICU patients, ADA relied on case series and retrospective analyses, which will ultimately need to be subjected to randomized, prospective trials. In the meantime, recommendations for both critically ill and non-critically ill hospitalized patients are the same. A pre-mel or fasting blood glucose target less than 140 mg per deciliter and random values of less than 180 mg per deciliter. A tighter goal of 110 to 140 mgl per deciliter, however, may be beneficial in specific subgroups of patients, such as open-heart surgery patients. For perioperative insulin needs, KAG should receive her usual basal insulin dose, insulin glargine 24 units, on the night before surgery. If the basal insulin is normally administered in the morning, the usual dose can still be given for patients with type 1 diabetes. For those with type 2 diabetes, 50% to 100% of the basal insulin is administered the morning of surgery. Correction doses of rapid-acting insulin can be administered the morning of surgery if the blood glucose is more than 180 mg per deciliter. If a current A1C is not available, it can be measured to assess the patient's glycemic control before admission. Most insulin infusion protocols include the use of IV regular insulin and maintenance IV fluids, either 5% dextrose in water D5W or D5W with 0.45% normal saline, that is 0.45% sodium chloride. For a patient requiring fluid restriction, 10% dextrose in water D10W may be used. The adjustment algorithms are used by nursing to change the rate of infusion in units per hour, depending on the blood glucose level. Most often, the insulin infusion is prepared in a solution of 1 unit 1 ml normal saline, e.g., 100 units of regular insulin in 100 ml of 0.9% sodium chloride. A dedicated IV line is used for the insulin infusion to avoid iatrogenic hypoglycemia. The insulin infusion is connected to the maintenance IV containing dextrose, can be Y-connected. Because insulin binds to plastic, the insulin solution should be flushed, e.g., with 20 ml through the IV tubing before the line is connected to the patient. An IV dextrose infusion is maintained while a patient is on an insulin infusion. Most patients need 5 to 10 grams of glucose per hour, or D5W or D5W 0.45% sodium chloride at 100 to 200 ml per hour. Additional maintenance fluids and electrolytes can be administered via a different port or line. Some protocols include an initial bolus dose of insulin. The initial insulin infusion rate is primarily based on current blood glucose level and BMI. Other factors such as body weight, current daily insulin requirements, and renal function should be taken into consideration. An initial rate of 1 unit per hour is common. It can range from 0.5 units per hour to equal to or more than 2 units per hour. The choice of initial infusion rate is not critical but should be based on patient history. A rate of 0.5 units per hour is appropriate for a patient who has never previously received insulin, whereas 2 units per hour would be appropriate for a patient with known insulin-dependent diabetes. Adjustments in the insulin infusion rate are determined by blood glucose levels every 60 minutes until the blood glucose is stable and close to target. Then, the frequency of blood glucose testing may be reduced to every 2 to 3 hours. Algorithms should consider both the current and previous blood glucose level, the rate of change of the blood glucose level, and the current infusion rate. Insulin infusion should be started at least 2 to 3 hours before the surgery to titrate to the desired level of glucose control. Examples of protocols are available on the Institute for Healthcare Improvement's website, available at http://www.ihi.org/ihi/topics/patient-safety/medication-systems/tools/closing parenthesis, and many are published in the medical literature. Thus, KAG's usual subcutaneous insulin regimen should be discontinued, and she should be initiated on an insulin infusion that is adjusted according to an algorithm. Throughout the perioperative period, she should receive a minimum of 100 grams of glucose daily to prevent starvation ketosis. Assessment of interfering substances with point-of-care blood glucose testing is particularly important for hospitalized patients. Some immunoglobulins and dialysates contain non-glucose sugars, including maltose, xylose, and galactose, which can interfere with glucose measurements with glucose dehydrogenase pyrroloquinol quinone test strips will falsely elevate the reading. Blood glucose concentrations should only be performed by the laboratory in these patients. So there you have it, our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 328.